Croeso, welcome everybody. Good afternoon. Thank you for all being here today. Welcome to Barrod's 9th session in our webinar series, the Manifesto Sessions. I'm Sian Roberts, Barrod's Operations Manager, and I will be your chair for today's session. So the Manifesto Sessions bring the powerful calls to action from our manifesto to life, one session at a time. Our manifesto is called Setting the Blueprint for a More Equal and Prosperous Wales for People Who Use Substances. Each webinar is focused on a specific ask from our blueprint, offering space to explore what it means in practice, why it matters, and how we can all play a part in making it real. You can download our manifesto from our website, and you can find a link to this in the chat box. On our website, you can also download our own policy papers in both English and Welsh on each of our asks, giving more in-depth overviews of each topic. So to bring us on to today's topic, it's about harm reduction centres and memorandums of understanding. As part of our Setting the Blueprint for a More Equal and Prosperous Wales, we want to establish memorandums of understanding to enable the implementation of enhanced harm reduction centres in Wales, also known as Overdose Prevention Centres, safer injecting facilities and drug consumption rooms. Enhanced harm reduction centres have long been part of effective, evidence-based harm reduction responses to health-related matters due to substance use, and over 120 facilities are currently operational worldwide. Establishing and operating enhanced harm reduction centres would be subject to the Misuse of Drugs Act, which means that to legalise their establishment and operation in Wales, a working agreement must be drawn up with law enforcement, such as MOUs with each police force in Wales. This would guarantee that those operating the facility would not face legal challenge or be prosecuted. I'm very excited to introduce our speaker today, Dr. Saket Priyadarshi. He is joined as well by Lynn MacDonald and Gillian Ferguson to help with questions a bit later on. But Saket is the Associate Medical Director in Greater Glasgow and Clyde Alcohol and Drug Services, and he has led on a number of service developments in Glasgow, including Scotland's first heroin-assisted treatment service and the safer drug consumption facility, which opened last year. Today, he's going to be talking to us about that experience. Welcome, Saket, and over to you.
Thank you very much, Jan. Thank you for the invitation, and I'm looking forward to the discussion that follows my presentation. So I'm here to talk about our service, the Thistle. The Thistle is Glasgow's Safer Drug Consumption Facility, the first sanctioned drug consumption facility in the United Kingdom, as you heard, based on a huge amount of international evidence from other facilities across the world. What I wanted to do was just give you a little bit about the background to the service, so a little bit about the service update. And we have just recently marked the 1-year anniversary, the first year anniversary of the service. And I want to share with you some of the learning that we've had to date and our plans for the future before we open up for discussion. I will spend a bit of time on the legal framework, but I think we can perhaps get into the more detailed nuanced discussion on the legal framework that we have managed to negotiate in the discussions afterwards. I want to acknowledge a huge amount of people who have been involved in this work. I can't name all of them or all the organizations involved. Just some of them are mentioned here, but in particular are just two groups of people that I really want to thank at every chance I get. First of all, our staff, our fantastic staff who've taken on the challenge of delivering the UK's first drug consumption facility. They do this day in, day out. They're a fantastic staff group, and you'll hear more about them later. And secondly, we wouldn't have been able to deliver the service that we have at the moment, a service that we're very proud of, without the input of people with living experience through our recovery groups in the city and our reference groups in the alcohol and drug partnership. So many thanks to them. So Glasgow has been a city which has experienced many harms related to problem drug use because of the high prevalence of needs in the city and high the prevalence of problem drug use. And we've talked about whether a drug consumption room was necessary in the city ever since I've worked here almost more than 2 decades ago now. But it was really the outbreak, the unexpected and sudden and severe outbreak of HIV in people who inject drugs in Glasgow City in 2015 that brought the issue of a drug consumption room into more serious consideration. We discovered that most people, the overwhelming majority of people who were involved in the HIV outbreak, were people who were injecting in places like this, injecting away from home in outdoor places in Glasgow city centre, predominantly, or just to the east end of Glasgow city centre. So our Director of Public Health and the chairperson of our Alcohol and Drugs Partnership commissioned a formal public health needs assessment for people who inject drugs in public places in the Glasgow city centre. And we published this eventually as a report called Taking Away the Chaos Report. It's easily available on the NHS website, and I'll give you a link and a reference to that later on in the presentation. That investigation and report led to a number of recommendations, and I've really summarized about a year's work into 2 slides here. One recommendation was to improve the current services that there existed for this severe and marginalized population, a complex needs population, to improve the data collection around public injecting, but also to pilot 2 evidence-based services and interventions that had been successful elsewhere, but we didn't have in an otherwise quite comprehensive harm reduction service in the city. So one was a pilot heroin-assisted treatment service, and the other was a pilot safer injecting facility. A pilot heroin-assisted treatment service does not require any changes to the law. It can be delivered through current legislation, licensing from the Home Office for the building to run the service, and licensing from the Scottish Government for prescribers to prescribe heroin to people who use drugs. A safer injecting facility, though, however, is associated with risks of, the reality of a number of breaches of law, particularly the Misuse of Drugs Act. And so there's a lot more challenge in delivering this and requires a bespoke legal framework. As you know, we hadn't been able to achieve a legal framework for a drug consumption room until quite recently. In 2018, when we asked the Lord Advocate of Scotland for the permissions we needed to run a drug consumption room, the Lord Advocate at that time declined, and therefore we made the decision to implement a heroin-assisted treatment. And you can see in the top right-hand corner the injecting booths of a heroin-assisted treatment in the service that we call the Enhanced Drug Treatment Service, which has been running now for 6 years or more. And that opened in December 2019. However, we continue to press the case for a drug consumption room, because although the HIV outbreak was novel, it did not dissipate quickly. You can see in the left-hand side that there continued to be rises in the HIV population of people who inject drugs in Glasgow City. And on the right-hand side, you can see that the issue of public injecting not only did not go away, but actually worsened as we saw a movement from heroin to cocaine with increased frequency of injection as well. And actually, the HIV outbreak was the harbinger of a wider national emergency in relation to drugs. You see steep rises in drug-related deaths that happened from 2014-15 onwards in Glasgow City, across Scotland, and the Scottish government issued a statement that there would be a response to a national emergency around a public health emergency around drug-related deaths. And in Glasgow City, we saw very much in parallel rises in drug-related deaths in the 2015 to 2020. Thankfully, in more recent years, as the blue line in the middle shows, we are seeing a downward trend. But we continue to make the case for a drug consumption room as our drug-related death figures were rising. And at that time, we gained a lot of support from a whole range of stakeholders, including the Royal Colleges and leading health journals as well. In 2023, a new Lord Advocate was appointed in Scotland, and she reviewed our case, and we were delighted in September 2023 when the new Lord Advocate made a statement that she would be prepared to consider a statement of prosecution policy that would allow us to deliver our proposed drug consumption facility in Glasgow City. Now, this was based on there being no changes to the Misuse of Drugs Act. For 3 or 4 years, there had been a debate between the Scottish government, which was supportive of drug consumption facilities, and the UK government at that time, which was not, about whether primary legislation could be enacted at Westminster. The Scottish government has a lot of powers devolved to it, but unfortunately the Misuse of Drugs Act was not devolved to the Scottish Parliament. And therefore, we required, in the absence of support from Westminster, required a local solution. So we worked with the Lord Advocate's officers to reassure them that we would be able to deliver a drug consumption room safely with no breaches of other law. And again, we can talk more about this in the future, but that we would require people who came into the service to be not prosecuted for the possession of drugs. So the statement of prosecution policy essentially says it would not be in the public interest to prosecute an individual attending the facility for an offence in terms of Section 5(2) of the Misuse of Drugs Act 1971. The Lord Advocate based her statement of prosecution policy on assumptions that the service would be located to near already existing public injecting sites, which is where the Thistle is sited, that it would be co-located with other relevant services, so there would be a range of other services in the building, that we would embark on a robust community engagement exercise, which we have done and we can talk more about later, and that there would be a robust independent evaluation, and this is very much in place. And we were able to assure this the Lord Advocate of these, so that in January 2025 we were issued with a final statement of prosecution policy, which allowed us to open. And so the service opened on the 13th of January 2025 at Hunter Street Health and Care Centre, which is a pre-existing site with a whole range of other services there, which is well known to most of our target population. It's just to the east of the city centre. So it is about 10-15 minutes walking distance away from some of the most frequently used public injecting sites in the city centre, but it's also co-located very closely within 5 minutes, 10 minutes of sites in the Carlton area of Glasgow, which is the neighbourhood in which the service is sited. You can see on the right-hand side that the building was revamped, refurbished quite significantly to deliver a much more psychologically and trauma-informed interior space than the ones we had previously. And that's the reception that you see there. And I'm going to show you some more photos from inside the service shortly. So we are open 9 to 9 every day of the week. So we were opened on Christmas Day, we were open on New Year's Day. The service is co-located with access to drug treatment, to bloodborne virus and sexual reproductive health services, to housing supports. And the aspiration was to have GP services, and we now have them, though they weren't there at the start of the service. We also have input from an acute clinician providing almost hospital-like care in the service to prevent admissions to hospital. The team, we are lucky to have a multidisciplinary team of medical, nursing, social work, and harm reductions and psychology roles within the service. We're very much based on a medical model of a drug consumption facility. And again, it will be interesting to have a discussion about different models that are possible, but we've very much used the model of a very highly clinically governed service such as that exists in Sydney as a format for ourselves, because we are mindful that the first such facility in the UK needs to be as safe and effective as possible. We have outreach services. People register with the service confidentially, as in they do not need to give us their full names and details. We use the same NEO system. I don't know if you're familiar with NEO system, but it's the system that we use for our IEP services across the city and the health board. We have we've now had approval for a drug checking service pilot, and we hope to have that operational not in the Thistle itself, but in the building, so co-located with the service. And I'll talk a bit more about an inhalation room later on, but unfortunately we were not able to progress with the implementation of an inhalation room in the current service. So these are the chat rooms. We don't call them interview rooms or even consultation rooms, because our feedback from people with lived and living experience in our reference groups was that people wanted a chat. They didn't want the formality of language that's associated with other services where they had more challenging reviews and assessments and interviews. So these chat rooms are where we see people after they've registered at reception. And in these chat rooms, we might ask people about what drugs they're using, how they plan to use them, the experience of using them, and wider needs that they have that we can try and address that day. At our initial, when we opened initially, some of these discussions were taking a bit too long for service users. So over time, we have kept them as short as possible. But what we do in the first visit is definitely go through some of the rules of the service, primarily the most important being you are not allowed to share or deal within the service. And this is the injecting space, or the using space that we have. We have 8 injecting booths. Injecting booths are cleaned before and after every use. A service user coming into the space will be allocated a booth by a nurse, and they'll use their, you'll see that there are mirrors available for nurses to see over some service users' shoulders if necessary. There's a degree of privacy. Some of you may have visited the service. If not, I'll talk more about how you can come and visit, but please do come and have a look about to see the setup. We have plenty of space to manage medical emergencies, and as you'll hear, we have a number of those to manage. In our health rooms, which otherwise might be called treatment rooms, we have things like vein finders, and we do a lot of wound care in these rooms as well. And this is often where our acute clinician and our primary care team, bloodborne virus services, sexual reproductive health services will see people as well. This is the post-injecting recovery area. We had thought this area would be busy with people who had used heroin, but as you'll see, the number of people who are using heroin is not as high as we expected in the service. So this is probably the least busy area of our service. People who use cocaine, they inject cocaine, they often do not want to sit around post-injection and are ready to move on. But people who've injected heroin are often groggy and need a period of time to recover, or sometimes have more prolonged assessments before they move on to the lounge area. And this is really the sort of the space where we hope the magic happens. This is an area after people have used where they can just relax, spend a bit of time having a cup of tea, maybe a little bit of food as well. We don't serve meals, but we have light snacks, predominantly carbs and carbs and carbs. In this area, we have our staffing groups available, but most importantly, we have our harm reduction workers here. We have 4 harm reduction workers, all of whom have experience of problem drug use and recovery themselves. They're deep in recovery. They've also got professional experience of having worked in other relevant organizations and know this population well. And this is where they do a lot of their relational work and nudging and supporting people into engagement with a whole range of other services, the most common being housing support. There, you'll see that the area is split up into different areas. So some people who don't want to sit with each other can have some separation. People can have a bit of privacy, and there's a very nice sort of cafe style area there as well. We also have an outdoor smoking of tobacco only space. And this was deemed as absolutely necessary, and again, something that the reference groups really pushed for, because first thing people want to do after they've used is have a smoke. And if we didn't have this space area, we would potentially lose them from this service. Our most important resource, of course, is our multidisciplinary team. And this is a photo taken by me of my colleagues just before our very first shift on the 13th of January. A very excited and nervous group. We've managed to retain almost all the staff in the 13 months of operation. I'm sorry, the alarm has gone off here. It's the test. Tuesday is a test day, so just bear with me. It'll stop shortly. But yeah, so we've got fantastic, motivated, enthusiastic staff group who are now, I think, very expert at what they do. And as I said, we have high rates of retention in that staff group. And just some service data to share with you. I'm going to just give you the 12 months data. So from the 13th January 25 to 12th 1st 26, 575 different people registered with the service, and you'll see the male-female ratio is about 3.5, 4 to 1, 3.5 to 1. Probably an underrepresentation of women registering, and one of the challenges we have is actually not just registering, but women injecting. We find that the ratio becomes even less. So we can talk about access for women later on as well. We saw in the first year that there were more than 11,000 visits and almost, 7,827 recorded injecting episodes within the facility. But actually, it's the real injecting episodes were more than that, because what we record is every use of the of a booth, injecting booth. But it may be that people inject 2 or 3 or more times while they have access to the booth. This is the service access data, and you'll see that towards the end of the year, it grew and grew. This is only for 13 days or 12 days of January there. That's why it's so low. And same with injecting episodes, more and more injecting episodes happening as the confidence in our service user population grew. The really surprising thing has been the amount of cocaine being injected compared to heroin. We knew that cocaine use was rising, but as you can see, the blue is the cocaine percentage of people who are injecting cocaine. The dark blue purple is heroin, and the orange is cocaine and heroin snowballing. And you can see that in some months, if you add the, for example, in January, if you add the 81% of cocaine with the other percentage, which I can't read, of cocaine and heroin, it's almost 90%, 88% of injecting episodes are cocaine related, and only about 12 to 20 are heroin injected. And linked to that are the medical emergencies. So we've had 93 medical emergencies. They tend to happen more when there's more heroin use. And by month, you can see the months here. In February, we're seeing about 25% of heroin use, and we've already had 12 medical emergencies in February. So medical emergencies are very much linked to heroin use. Just sharing with you, one of the arguments for a drug consumption facility is not just about what it can do for people who use services, but also what it can do for the community. And this is data around the drug-related litter, so needles in particular, found in the Carlton area in the last, since May 2025, and you can see very significant reductions in needles in the surrounding area since then. The December data, that tower there, is because that included sites that had accumulated needles for a long period of time that were cleared up at that time as well. So it's not just strictly December data. So just a few things about what we've done to service. Although we've opened the service, it's not the job done. It's a service that needs to develop and respond to the needs of service users. We've set up a service user forum, which one of our alcohol and drug partnership senior officers is facilitating. It gives us fantastic feedback, but of course we have the challenge of responding to that feedback. And an example of our response would be, for example, what we did about the registration and the initial discussion and follow-up discussion processes, trying to shorten that as much as possible so people could access the injecting booths, which is what they really wanted, as quickly as possible whilst being safe. And here's some work we do. This is some artwork, for example, from the service user forum that Claire, our senior officer, facilitates. And she sent me photos of lots of different artwork, but I've just chosen this tree, for example. So we do try and offer more activity in this space than we initially did, and that will develop hopefully even more as time goes on. Our outreach services are very important now, to not just, we had initially thought the outreach service would be important for us to engage service users, but actually they've become very important part of our community engagement plan. They help reassure the community that we will respond to any pockets of outdoor injecting that exist in the area. We've established a GP service. They provide input 2 days a week, and that's been very successful, and there's a good uptake of that. As I described earlier, we now have an acute consultant, a hospital consultant, health clinic up and running. The dental services locally have wanted really to get involved, and they've now set up a mobile dental van just at the gate of the service, which again is a really key issue for many service users, not just at the Thistle, but in the whole building. The Thistle nursing staff have engaged with the opportunity to ensure vaccinations, a whole range of vaccinations to this highly vulnerable population. And we've implemented we've had the input of advocacy services, and we want to bring in the welfare rights services into the Thistle as well. The Thistle is just one of a whole range of services that our Glasgow Alcohol and Drug Recovery Services provide, and I'm not going to go through all of these, but we hope the Thistle, as well as providing a harm reduction service, is also a gateway to a whole range of other services, and that's the aim and the aspiration of the service model that we have. And certainly we're seeing some evidence. So we've got 80 referrals have gone into the alcohol and drug recovery services systems. And we're now even hearing that a few of our patients, service users, have actually entered rehab settings. One of them even completed residential rehab. But we do have lots of learning. I talked about access for women, and again, I think we should pick that up later. The changing of drug trends has really caught us by surprise, and the move towards inhalation recently is very important and significant, and we are therefore building a business case for an inhalation space. We hope to have the drug checking service up and running soon. Our statement of prosecution policy really allowed us to open the facility, but there are limitations to our legal framework, and the inability of service users to share their drugs as they do outdoors has been challenging. And tourniquets, we're not able to, believe it or not, to provide tourniquets, though we can provide needles and so many other paraphernalia. When my colleagues will probably want to talk about community engagement as well, but the most important thing to here to say is that when you're doing community engagement, it's very important to begin with a message of how these services can contribute to the betterment of the environment for the community, rather than focusing necessarily on outcomes for people who use drugs. And we work very closely with our police colleagues. If you're going to do this, be prepared for the blitz of negative headlines. It's very difficult to control, but your comms and engagement team and your press team need to be right on it. And we've also worked closely with media to try and give more positive picture of the service and its impact. And I would suggest everybody to have a look at the London Review of Books article by Danny Garavelli, where she spent a week with us in the service. And that really informed probably the most nuanced article about the service that there has been to date. I'm not on this, but I wouldn't suggest anybody spend any time on this platform, because rational discussion is not really possible there. So we do a whole range of other public engagement exercise. We have a website. We've developed some videos. We've got a very clunky service user leaflet, a service leaflet on the right-hand side, which we are totally changing, and our service user forum was designing a new leaflet for us. I'm just concluding here. There's a whole range of references at the last slide. I'll send you the slides, Shia, and then you're welcome to share them. But these are some further reading items that you have.
Thank you
Thank
so
you.
much. That was thoroughly interesting and thought-provoking. I'm just going to ask your colleagues, Gillian and Lynn, to unmute now, and my colleague Lucy will spotlight you two as well, and we're going to go straight into the questions. But before we do, Gillian and Lynn, would you like to introduce yourselves, please?
I'm Lynn MacDonald. I'm the service manager for the Thistle and a number of other services within EDRS in Glasgow.
Hi everybody, I'm Gillian Ferguson, and I'm the coordinator of the Alcohol and Drug Partnership in Glasgow City.
Brilliant, thank you, and a warm welcome to you two as well. So we've got loads of questions as we anticipated in the Q&A for you, so I'm going to jump right in with the first one. What were the key political turning points that shifted the conversation from not possible to now happening with the Lord Advocate?
The real issue was that the worsening crisis in relation to drug-related deaths in Scotland and drug-related harms, whilst there was a lack of progress in the drug consumption room facility being opened. So the Scottish Government had supported, so when we made our case, our governing board, the Integrated Joint Board, supported our case. The Glasgow City Council then had a motion to support the case, and it had support there. It went to the Scottish Parliament, which voted in support as well. Of course, not all the parties voted in support, but there were majorities there. Then that sort of period of time where there wasn't a solution found in terms of primary legislation in Westminster. During that time, unfortunately, our drug-related death crisis was worsening. The HIV prevalence in Glasgow City, although not as high as in the peak, wasn't still not reducing as quickly as we wanted. So in that background, I think there was a pragmatic sort of view that we needed a local solution. And of course, we also had the appointment of a new Lord Advocate who reviewed the case again. We had been working in the background with Scottish Government, with Police Scotland, with Crown Office, to keep sort of reviewing how it might be possible to deliver this within current legislation. Okay. On the point of building a case, I think the other thing I would say is that you'll notice that we did a very formal and very methodical public health needs assessment that really sort of described the population, that described their needs, matched them against the international evidence base of interventions and supports that might be successful. And so it was a very step-by-step approach to, well, actually, we've got X, we've got Y, but we don't have Z. Let's try these things. So I think I can't emphasize the importance of doing things in a robust, evidence-based, step-by-step way to build a case. The final thing around that is the statement of prosecution policy that we have is just for the service user bringing drugs into the facility. Okay, so we have had to do a lot of work ourselves to assure ourselves that there are no other breaches of the Misuse of Drugs Act or other criminal activity within the facility, and we have to ensure we've had a lot of advice from our own legal teams and counsel.
Thank you. That's really good advice and food for thought for us here in Wales. There was a linked question to that one that you touched on in your response, which was around the increase in drug-related deaths you were experiencing in Scotland. And the question was around what were the causes of that increase that meant it became a public health emergency?
So, I mean, that's a talk and a seminar and long discussion in itself. It's a tragedy, really, and a crisis. There are very many different theories, but the 2 or 3 sort of key issues that have emerged over time have been the changes in drugs used. So in particular, the atypical benzodiazepines that became available in Scotland and became used in the street market. So it is starting off some time ago with phenazepam, then moving to tizolam, and particularly that move to tizolam, you saw more and more drug-related deaths with opiates where tizolam where it was involved, and benzodiazepines accounted for, I think, somewhere like 80% of they were implicated in 80% of drug-related deaths as we got to the sort of the peak of this period. So that's I think for me a key driver. Cocaine becoming more involved, poly drug use becoming more problematic. Scotland has, or certainly did at that time, had a very large percentage of people who were not in protective treatment and engaged in services. So maybe even less than 40% of people who use drugs were engaged in treatment as well. So it meant there was a higher vulnerable population than other areas. And then there's there's things that are much more harder or more challenging to actually sort of scientifically prove, but things such as at the time of austerity and reduction in wider services and supports for people, a whole range of deaths of despair increased, didn't they, from suicides to drug-related deaths to alcohol-specific deaths and as well. So there are lots of theories. I don't know if Gillian and Lynn want to add to that, but those are some of the key observations I would make.
Just the only addition I would make is that we also in Scotland and in Glasgow, we've a very good process around counting all drug-related deaths. So it's a really robust process. We don't miss any. So the situation is horrendous. I mean, it's absolutely awful. But our 5-year trend has started to turn, so we're ever hopeful, and we'll just keep trying, coming up with new initiatives like drug consumption rooms.
Yeah. Absolutely.
So I mean, I think Gillian's last point is really important. You'll know that the recent papers around the underestimate in England and Wales may be as much as 60% underestimates, and so that is important to bear in mind.
Okay, thank you. Move on to a slightly different theme of question here then. It's linked to how did you bring local residents and businesses on board, and that's part one of the question, and the second part of the question is, what language did you find most helpful? Is it around harm reduction, public health, prevention, safety? Tell us what you've learned and how we can learn from you.
We started as early as we could, not as early as we should, but as early as we could in terms of community engagement. And it was engagement rather than consultation, and that once we got approval, the consumption room was happening, but we wanted to engage with community. We did it all wrong in our first meeting, in that we went to a community council meeting and we sat at the top table and the audience faced us, and it was quite confrontational. And immediately pivoted, and as Saket says, pivoted to looking at it from the perspective of the harms the community was suffering rather than the individuals. We had a series of engagement sessions set up within local venues, at the heart of the community, with a cup of tea and a chocolate biscuit and small tables, so that it didn't, there weren't crowds of people whipping one another up. There was a lot of anxiety, a lot of anger. And we continue to work very, very hard with the community, local businesses, local residents, faith leaders, etc., etc. We set up a community engagement forum, and both Lynn and Saket and I, both Lynn and Saket are in that forum as well. Saket chairs that masterfully. And we deliberately invited members, local residents in particular, that are not fans of the service, because we wanted to be really transparent and give it some legitimacy. That is hard work, but it's very much worth it. It really is worth it. We continue with that community engagement. Media plays a huge role in that, unfortunately. Sometimes positively, sometimes constructively, but we've been quite let down. I feel we've been let down when we worked really, really hard, particularly Lynn and Saket, engaging with the media and trying to help them understand what we were trying to do with the project. And that didn't, that doesn't give them clickbait. Therefore, they wrote different kinds of articles. So that's really disappointing. But I rather naively thought that once the service was up and running, particularly a year in, that there would kind of quieten down, and that has not happened. Whether or not that's because there's an election coming, I don't know. We have suffered because some people have sort of parachuted into the area and made it an election issue, and that's really, really unhelpful. I feel like the community's being exploited in that respect, because there undoubtedly are community harms that we had to show respect for, and they're really legitimate anxieties that we had to show respect for and help people understand that the thistle, we believed, would really alleviate many of those harms and really contribute to an improved quality of life in the community. And we've got a lot of really good anecdotal evidence that it is doing that. We also have continued anxiety and anger from different parts of the community who have loud voices, maybe not hugely representative voices, but loud voices.
I think as well, you covered that really well, Gillian, in terms of what language is helpful to use. I think we learned very quickly that it depends on your audience. When we went to local residents and talked to them about how it may benefit people who use drugs, that wasn't what they wanted to hear. So you really need to think about what you're saying, basically dependent on your audience. You need to think a bit about who you're speaking to and think about what their very specific needs are in terms of that information you're trying to get across there, I think.
Some really good points for consideration for us there, if we get to the point in terms of public engagement very early. Okay, so there's questions here that I'm guessing all three of you could answer. Again, it's a two-parter. What was the hardest moment in the journey for each of you? But also, what was the biggest surprise that you encountered on your journey, good or bad?
I think the hardest bit for me was the lead up to opening, with a number of delays, and it was very frustrating. It was quite difficult. It was the impatience that we felt, that I felt certainly, in terms of the risks that we were trying to mitigate against, but the continued risk to people while we were delayed in opening the service. I found that very challenging. For me, some of the biggest surprises is how quickly people have engaged and been very honest with us. We've set up the service in a manner that means they can use it confidentially. They don't need to give us a lot of detail. We just need initials and a date of birth that would indicate they're over 18. But actually, people have been much more willing to give us quite a lot more information more quickly than we first anticipated. So there are still some people who are slightly anxious about the service and want to get to know us, and there's still an element of mistrust. Why would we let people do this, and why have you got social workers or people spying on me? But really, and I think probably it reflects back to something Saket mentioned earlier, and that the team that are doing the shifts on a day-to-day basis are fabulous. They're very trauma-informed, they're very open to listening to people. We've got a good team there that absolutely gets what they need to be doing for people in terms of what level of support should be offered.
One of the things I found very hard, and it's the same audience because it was surprised me as well in how it changed, was when I began engagement specifically with our recovery communities, who are a real powerful force within Glasgow, and very understandably very focused on abstinence. And I began initial engagement sessions with the recovery communities and got roasted, which is quite hard. But as we worked with them and helped them learn about what we were trying to achieve with the service and how it could look, and engage them in influencing that design, they became part of the reference groups that influenced the design, and watched them, see the potential in a service like that. Our North East recovery community, which is a huge recovery community within Glasgow, has become one of its biggest champions. And that it surprises me still that, the change in attitude and the pride that they have in the service that they've helped develop. So it was very hard at the beginning, but it was really worth it going there and through the middle of it and coming out the other side.
Yeah, quickly from me then, Sian, the hardest and most disappointing elements, I think some of the really toxic media and social media stuff has been really hard. Yeah, hard on teams, hard on all of us involved in the implementation, a lot of misinformation, real sort of, really extreme abstentionists of views that it's very, and the challenge there is it's very difficult to engage with that in a rational perspective, but the way that mainstream media, clickbait, as you said, as Gillian says, rides on the back of that for clickbait purposes, it's been a bit of an eye-opener actually as to how the media works. And it's very difficult to engage positively in that space. So that has been one challenge. The positive and surprising thing for me, and I'm just going to say it, was around how many staff wanted to come and work. And we found our recruitment was not
full-time job.
Was not nearly as challenging as we thought it would be. We had huge amount of interest in the jobs. We had our pick of cream of the crop. We involved lived experience reps in all our recruitment processes. And we have a highly skilled, very varied group of staff who are extremely enthusiastic, doing a great job, and almost all of them are still working with us 13 months down the line.
I think the only people who've lost to promoted posts, so I'm okay with that.
Yeah, it sounds like a wonderful place to be. I'm sure everyone on the webinar will be looking for vacancies and moving to Glasgow.
You'd be very welcome.
We have actually run out of time, and there's so many more questions that are brilliant questions in the Q&A that we don't have time for. But I'd like to take this opportunity to thank you all for attending our webinar today. We look forward to seeing you in April, where we'll be hosting our final webinar in this series. So keep a lookout for the date of that and book on. And the focus of that session is going to be on our updated delivery plan or strategy and how difficult it is working in the vacuum without one. But finally, a huge thank you to Saket, Gillian and Lynn for a thoroughly interesting and inspiring webinar today. Thank you also to the webinar team behind the scenes for bringing things to life today. So that's Rob, Lucy and Verity. And thank you everyone for your brilliant questions and attendance. And I hope you have a great rest of the day.
If you have been affected by any of the issues discussed in today's podcast, please reach out. Barod have a free and confidential live web chat service that is available 7 days a week on our website at barod.cymru, where you can chat to a trained support worker. Alternatively, you can contact Wales's National Drug and Alcohol Helpline, Dan 24/7, either by calling 0808 808 2234 or text Dan to 81066.